So hopefully people are getting, set up and settled in, and maybe we should just get going and get started. Oh, and Jeff, usually, we allow, maybe 10 minutes or so at the end for questions.
Great.
That's okay. And sometimes people put things in the chat, but just sometimes questions. Does that make sense?
Yep. Yeah, I had planned for about 45 minutes. Hopefully I
Yeah,
can
that's
get through
great.
everything.
That's great. So we'll get started. So we're at our November lunchtime talk. I'm Arthur Reynolds, HCRC, and we're really delighted to have Jeff Waid from the School of Social Work, where he's a professor here at U of M, and he has, like we do in the HCRC, has, wide-ranging interests in things like, prevention science, health equity, family support programs, and also, really with a particular, emphasis on child maltreatment prevention, and how that plays out, and how that not only, early childhood programs and family support programs can prevent child maltreatment, but can prevent child maltreatment, but also sort of enhance mental health. And he's done a lot of work on, these intersectional topics that are of great interest to us, because in HCRC we're interested and have done a lot of work in child maltreatment prevention, but also in, also education and health equity. And so the topic of his presentation today, mental health and child maltreatment prevention, current evidence and future directions, is a perfect fit for the larger field of not only life course development, but prevention science and human capital. So we're really delighted to have Jeff, come and talk to us. Thank you very much, Jeff. So you can take it away.
Thanks, Arthur. I appreciate that introduction. It's so great to present to all of you. I'm really looking forward to a good discussion today. As Arthur mentioned, I'm an associate professor in the School of Social Work. My background, I actually came from the field of child welfare as a family preservation and intervention specialist. So I did a lot of work with families in their homes on maltreatment related risks, and really saw a lot of returning to the child welfare system. A lot of people who made contact often came back. We had mixed effectiveness in terms of preventing and intervening in child abuse and neglect. So that was really the impetus to pursue a PhD and kind of where I am today. So I just want to offer a couple of acknowledgements before we get started. The number of organizations have supported my research, including the College of Education and Human Development, the Hennepin University Partnership, and the Institute for Translational Research in Children's Mental Health here at the University of Minnesota. OVPR, Sauer Family Foundation, and the National Institute of Food and Agriculture have funded these projects. I wouldn't be here without my community and university partners, which include the Center for Advanced Studies in Child Welfare, Hennepin County Division of Child and Family Services, Intermediate School District 287, Minlink, Sherburne County, and Washington and Ramsey County. And of course, my co-authors, research assistants, and the study participants who provided data to help generate the knowledge and information that I'll share today. So I thought I would do a presentation in 3 parts. First, provide a little bit of context on how I'm thinking about the relationship between mental health, child maltreatment, and child welfare systems involvement. And I'll do that with a review of a study, latent class analysis of risk factors associated with repeated contacts with child welfare that was published in 2021 in Child Abuse and Neglect. Then I'll talk about current evidence, which is a systematic review of mental health targets and maltreatment prevention outcomes among primary and secondary prevention programs that was published this year in Children and Youth Service Review. And then future directions, how I've leveraged this information to develop a preventive intervention that's really designed to improve mental health and prevent child maltreatment through navigation to prevention and early intervention services. And this was just published in BMC Public Health this month. So it's pretty fresh. So just by way of context, child maltreatment is a significant social problem. Recent data suggests 7.9 million children were referred to child welfare systems for suspected maltreatment in 2019. 16.8% of these cases were considered substantiated victims, meaning there is a determination that abuse has occurred. 13.8% received what's called an alternative response, where systems think there's significant risk of future abuse, and enough so to maybe request family participate in voluntary services. And then the largest share, 56.5%, were considered unsubstantiated cases. These are people who are screened out, or an investigation occurs and there's no follow-up. And that's the population that I'm really interested in, is this 56.5% who come to the door of CPS, but then are released. I want to know what's going on with them. We know that people who have contact with child welfare systems have subsequent contacts or repeated contacts. It's very common. 30 to 60% of cases that are referred to child welfare get re-referred within 24 months. And 10.6 to 22.6% of victims experience a second maltreatment victimization within an 18-month period. And the risk factors that bring families to child welfare are complex and multidimensional. You know, they involve individual, family, community, macro system, and historical contributors. And I think that the ecological transactional model and cumulative risk theory are very helpful for thinking about, you know, how do things like poor mental health co-occur or interact with other risk factors to result in contact with systems, and what's the net effect of this over time. And I'm particularly interested in mental health and mental well-being among cases referred to child welfare. Research suggests that there's a threefold increase in child maltreatment referrals during the perinatal period if the mother has a mental illness. There's a 2.6 to 5.7-fold increase for CPS systems contact for mental illness or co-occurring disorders, and an 8-fold increase for families with serious and persistent mental illness. So mental health challenges are really common among people who come to the front door of child welfare. So the first study, I really wanted to look at how things were here in Minnesota. I specifically was interested in examining how maltreatment risk factors co-occur for kids who are re-referred or re-abused following a CPS system contact in Hennepin County. And to do this, I conducted a latent class analysis to identify potentially unique combinations of maltreatment risk, with a focus specifically on mutable risk factors, things like mental health, domestic violence, disability, things that are amenable to intervention. And then to determine if child, family, or case level covariates would be associated with the risk class or the latent risk class that the case ended up in. So to do this, we put together a secondary data set using MinLink data from the Center for Advanced Studies on Child Welfare. We used SSIS data, so this is the Social Services Information Systems database within MinLink, everything that the child welfare folks put into the computer. And we drew a sample of the population of youth who had contact with Hennepin County between 2014 and 16. This was roughly 20,950, I think, kiddos. And then from that sample, we looked for the kids who experienced a maltreatment re-referral or a substantiated maltreatment recurrence within 12 months of their index case. And we use the federal definitions for maltreatment re-report and recurrence. Those are sort of the federal benchmarks that assess how child welfare agencies are doing in terms of preventing and intervening in cases of child maltreatment. So we basically, if they've had a second contact within 12 months, we pulled their file. If they had a second substantiation within 12 months of the first, we also pulled their file. Just a caveat for the recurrence outcome, We made it so that the second maltreatment event had to be more than 14 days from the first. The reason for that being, once an investigation gets opened, oftentimes other allegations surface. And so putting that 14-day window in really kind of helped prevent against multiple different allegations being counted as separate events. If they were within one investigation, they were kept within one investigation. And we looked at maltreatment risk factors, which were derived from what's called the structured decision-making assessment, structured decision-making risk assessment tool, which is an actuarial risk assessment that looks at different factors. We included the risk factors that were mutable, things like additional caregivers, unmarried. We didn't put that into our model. We really wanted to focus on the things that could be intervened on to change. And they included disability or an emotional impairment for the child, domestic violence for the caregiver, mental health for the caregiver, drug and alcohol for the caregiver, and parenting challenges. So most of the risk factors we looked at were parent level, with the exception of emotional impairment and disability at the child level. We also looked at age, race, ethnicity, and gender, and the type of maltreatment that was reported at the first contact. We did a latent class analysis with maximum likelihood estimation. I prepared 5 different models with 1 to 5 latent classes. So a 1-class model, a 2-class model, a 3-class model, and so on. And then we sat down with our partners at the county to go over these different models and see if they made sense statistically, but also theoretically and practically. And the final model was selected based on a combination of statistical fit, but also theoretical and practical relevance. We did a post hoc chi-square and Fisher's test to compare the latent classes according to covariates to see if certain racial or ethnic groups or age groups were more or less likely to be in one class versus another. And I apologize for the small font here, but what you can see, and I'll maybe kind of use my mouse to kind of help guide our look at this. Of the 20,000 cases that were 20 or so thousand cases that were referred to see Hennepin County in the 3-year period, 4,390 experienced a re-report, and 694 experienced a maltreatment recurrence. The average child age at the index report was 7 years old. The gender distribution of males and females was nearly equal. Descriptively, Black children represented the largest racial group experienced a re-report, followed by white children and Native American children. However, Native American children experienced the highest proportional rates of re-reports, so they were re-reported at the greatest rates. The most common form of maltreatment was neglect, followed by physical abuse, and that was the same for maltreatment recurrence as well. For kids and families in the maltreatment recurrent sample, the average child age was also 6 years old, with a slightly greater number of female victims. Descriptively, Black children experienced the highest rates of recurrence, followed by white and Native American children again. Native American children also experienced the highest proportional rates of maltreatment recurrence, followed by Black and multiracial children. Interestingly, no children experienced a substantiated recurrence of sexual abuse, which I think is interesting from a prevention perspective. What's going on in cases of sexual abuse that's different? And why are the kids who are victimized sexually not experiencing subsequent victimization? I think it has to do with how we respond initially to those cases, the types of services we provide, and the types of follow along that occurs either at the family level or the organizational level. But it's an interesting question to think about how we might redesign services for kids who experience other forms of abuse. So table 2 here just looks at risk factors associated with re-report and recurrence without designating them to a specific latent class. For re-referral, domestic violence was endorsed in approximately 1/2 of the cases, mental health challenges in 1/3 of cases, parenting skill deficits and child disability in just under 1/3, and then a history of drug and alcohol problems in just under 1/4 of the cases. For maltreatment recurrence, domestic violence was present in nearly 2/3 of index cases. Caregiver mental health challenges were just under 1/2, 46%. Parenting difficulties just under 1/2, and drug and alcohol problems were present in about 37% of recurrence cases. Child disability, 29%, just under 1/3. So primarily, I think, just descriptively, domestic violence is really common source of referral to child welfare, and also really common in cases of maltreatment resubstantiation. The second table here, table 4, is presence of risk for each latent class for each sample. So this block of data here is the latent classes for maltreatment re-report. This is the latent classes for maltreatment recurrence. And these are the estimated means. So the proportion of cases endorsed for a specific risk factor within each latent class. Let's see. So in looking at the data with our partners and looking at the fit indices, 3-class models best fit the data in both cases. For the maltreatment re-referral group, class 1, we characterized as few identified challenges. Basically, this block that accounted for a little over half of the cases, we felt the caseworkers, either there was low presence of risk or there was low detection of risk by the caseworkers in this first latent class. A history of domestic violence was only endorsed in a 38%, mental health only 10%. The second latent class here, oh, and I forgot to mention, when characterizing the latent classes, we made the decision that if greater than 50%, if the estimated mean for a risk factor in a latent class was greater than 50%, then we use that risk factor to characterize the latent group. So this second group here, we characterized as mental health and domestic violence challenges. You can see that 63% of cases in this class were endorsed for domestic violence, and 68% were endorsed for mental health. Child disability and parenting challenges were endorsed at 45%. So mental health and domestic violence challenges co-occurred in approximately 26% of the cases. And then our smallest group of re-referral, here, 18% of the re-report sample, we characterized primarily as substance abuse, domestic violence, mental health, and parenting challenges. So more of the deep end cases, excuse me. All of the cases in this class 3 had a substance abuse issue as identified by the caseworker, but domestic violence was also endorsed at very high rates, as were mental health and parenting challenges. So, typically when and this is more, I think, speaking from my practice experience, child welfare systems have limited resources. So they typically devote those resources to the most complex and high-risk cases. So thinking about class 3 is the kind of risk profile that you would expect maybe to get re-referred and to require other services. These other classes, not so sure. I think that there's some questions about why are the majority of cases not being identified, and then what's going on with mental health and domestic violence. For maltreatment recurrence, that's this group here. Let me see where I got here. excuse me. 48% of the sample were characterized by domestic violence challenges. This was reported at 54% of the cases. The other risk factors occurring at lower rates, although parenting challenges were also present. The second class we characterized as mental health challenges, which were present in all of the cases. So 15% of the recurrent sample, every single case was identified as a mental health challenge. There were also some concerns for drug and alcohol, child disability, and parenting, although at lower rates. And then class 3, again, sort of thinking about our deep end cases, domestic violence was endorsed in 100% of the cases. There were also very high rates of mental health challenges, parenting skill deficits, and moderate rates of drug and alcohol or child disability related issues. So class 3, deep end re-referral, class 3, deep end maltreatment recurrence, domestic violence co-occurring with mental health challenges, pretty common in maltreatment cases. So we did a summary of case characteristics according to latent class membership. Again, we've got the re-report sample and then the recurrent sample. There were some differences in the types of kids and families that were re-referred. They varied by child age, race, Hispanic ethnicity, neglect and physical abuse allegations. Younger children, African-American children, I think were referred at higher rates. There were not differences by gender, mental emotional abuse allegation, or sexual abuse allegation. For the recurrence classes, there were differences in child age. They did not differ according to gender, Hispanic ethnicity, or maltreatment type. So younger children are more often the subjects of re-referral and also maltreatment resubstantiation. So this study really, made us think about how the system is currently responding. There are, I think, some challenges with how we screen cases that are referred to child welfare and the decisions we make about who gets accepted. There's not a lot of services available in the primary prevention realm. It is my experience as a caseworker and as a researcher that a lot of families get referred to child welfare because referral sources don't have anywhere else to send families. So I think that, for people who are intervening in cases of child maltreatment, we have to think about the co-occurring nature of risk, particularly co-occurring nature of mental health, domestic violence, mental health and domestic violence, and possibly substance use. Also, the primary types of maltreatment that are referred are neglect, followed by physical abuse. So I think that there might be a need for programs and services that ameliorate the poverty-related conditions that exacerbate mental health problems and other issues, other family stressors that bring families to the child welfare system's attention. So after I got the lay of the land of what's going on here in Hennepin County, which most people say is a representation of the broader state. Maybe it is, I don't know. But I felt like the next step would be to look at what kinds of interventions and services are currently out there, particularly primary and secondary prevention programs. And how are they looking at, like, what are they doing? What are they looking at? And are they effective? So, the current array of services are really designed to address the needs of kids and families after maltreatment occurs. Fewer programs and systems of care really engage and support these families early. So I wanted to know what was out there. And then also too, what I've read about child maltreatment programs is that the findings are mixed. Roughly 25% of randomized trials are found effective in preventing maltreatment. The larger effect sizes are for more recent programs with smaller samples. But that's not to say that we're not learning anything. These programs typically target parenting efficacy and ability. So I wanted to look a little bit deeper into that and see what was going on with respect to mental health and maltreatment outcomes in these programs. So the aims were really to just examine how researchers were conceptualizing, measuring, and reporting mental health outcomes in maltreatment prevention studies. And then hopefully this information would give me some ideas about future directions or things that we could maybe be doing differently. So we conducted a systematic review of studies published between the year 2000 and 2021. It had to be a primary or secondary maltreatment prevention program. We excluded tertiary programs because there's a pretty robust evidence for those programs already. We wanted studies that included at least one measure of mental health, and mental health was defined by the study authors, and one prospective maltreatment outcome measure. We searched 9 databases, found 1,106 records, 931 non-duplicate sources. We screened all of them. We did a full text review of 154 articles and ultimately included 33. We looked at recruitment and randomization, inclusion and exclusion, duration to follow along, participant characteristics, comparison of groups on attrition, intervention setting and characteristics, and then mental health and maltreatment measures and outcomes. Because mental health was so broad in how it was defined, we did not do a meta-analysis. We did a narrative synthesis of the results, and the studies were appraised. The internal and external validity were appraised using the Prevention Services Task Force guidelines, which basically just examines all these different areas that we extracted data on. So of the 33 programs, 22 of them were in-home services. These activities commonly focused on strengthening parenting knowledge, attitudes, and skill, improving parent-child relationships and interactions, strengthening informal and formal supports, engaging in problem solving, and connecting families to community resources. Group parenting programs, these were community-based and provided parents with support, education, and coaching on a range of parenting topics. Things like child behavior, effective parenting, emotion regulation, conflict resolution, positive discipline, anger management, etc. There were 2 online programs. One was a triple P, modified for online delivery, and the other was ePAL's BabyNet, which helped parents read infant signals and respond with warmth and sensitivity through daily activities. There were also 2 outpatient programs that compared parent skills with behavioral couples therapy to behavioral couples therapy and individual therapy. And then a second outpatient program provided life skills training and clinical services to new teen mothers. In our look at maltreatment measures, measures of mental illness appeared roughly 7 times more often than measures of mental well-being. The most common in this list here, this is in the order in which they appeared. So caregiver depression, parenting stress were by far the most commonly measured mental health constructs. Substance abuse, family violence, disruptive child behavior, caregiver anxiety, global mental health, marital conflict, and child hyperactivity. Those are the things that these prevention studies looked at. For mental well-being, much less often studied, but social support, self-esteem, self-efficacy, problem solving, and hope were what appeared in the research and what the authors considered to be mental health. Child maltreatment measures, this was really interesting to me. Self-report was overwhelming in studies of maltreatment outcomes. Self-report was the sole source of maltreatment outcome in 18 of the 33 cases. 4 supplemented self-report with CPS records, or 3 self-report and structured observation. 2 studies used 3 or more measures, self-report and hospital measures, CPS records only, CPS plus hospital records, and then the reporting source not clarified in 1 study. Although in that case, it was family violence. The authors didn't describe if that was self-report, observation, or some other measure. So 10 of the studies reported improvements to mental health and maltreatment prevention outcomes. 6 of these were home visiting programs, 2 were group parenting programs, 1 online program, and 1 outpatient program. These studies primarily reported reductions in child behavior difficulties, but also family conflict, parental substance use, depression, parenting stress, anxiety, and interparental conflict. 4 of the studies reported positive changes in 2 or more mental health measures concurrent with improvements to maltreatment prevention outcomes. Maltreatment outcomes were measured using self-report, hospital records plus self-report, and CPS records. 8 studies reported changes to mental health, but no differences in child maltreatment measures. These included 4 home visiting programs led by trained staff, 3 programs, home visiting programs led by therapists, and then 1 comparative effectiveness test, I think in Norway. Across studies, treatment group improvements were observed for parenting stress, depression, anxiety, and substance use. Improvements to child behavior, attention, hyperactivity, and general mental health were also observed, although by far parenting stress was the largest N in terms of mental health improvements. 4 studies reported improvements to 2 or more mental health measures. We had 5 studies that reported improvements to maltreatment prevention outcomes, but no changes to mental health. These included 3 group parenting programs, 1 nurse home visiting program, and 1 online program. These studies utilized self-reported measures in 3 cases, self-report plus structured observation in 2 cases, yeah, I believe I have to look to see. Yeah, so primarily self-report and self-report plus observation. So kind of worrisome, I think, when we're like asking a parent to self-report their maltreatment of their child. I think this is a limitation that's sort of emerging from this look. And then there were as many studies that had both mental health and maltreatment prevention outcome. The same number had neither a mental health or a maltreatment prevention outcome. These 7 of these were home visiting programs led by paraprofessionals, 1 nurse home visiting program, and 1 outpatient program. One of the programs did have negative treatment group changes to child behavior. And 1 study found that parents with higher baseline levels of depression were associated with more frequent referrals to CPS. So just thinking about what's currently out there with respect to primary and secondary maltreatment prevention programs, I think what we're finding is that these programs more often promote caregiver and child mental health than actually prevent maltreatment. Most of the reported mental health improvements were to children's behavior, parental substance use, depression, stress, and anxiety. And so I think that it might be helpful for us, if we're thinking about new directions to go, to broaden our conceptualization and measurement of mental health. Trauma is extremely common among families that are referred to child welfare, but those measures were not found in the primary and secondary maltreatment prevention literature. So I wonder about that. And I also worry about the way in which we're measuring child maltreatment. I think that we have to have multiple indicator approaches. And I worry when, a subscale of the parenting stress index is what organizations are using or research teams are using to define maltreatment. One thing that I didn't really see too much in the description of intervention studies was attention to socioeconomic and structural contributors to mental illness and child maltreatment. At least among families who get referred to, child welfare, they're overwhelmingly poor, often Black and Native American. They're referred at much higher rates. So we should be thinking about this, and we should be attending to this in our prevention efforts. And this really led me to my current work, which is focused on health equity and mental health promotion to prevent child maltreatment and adverse childhood experiences. And this, research I've been doing for a little while now is really thinking about, okay, we kind of know why kids get maltreated. We kind of know why they're getting referred to CPS. We have an idea of the types of folks that are getting referred, and we know that some interventions and services work. So, we don't have to throw out what we already know. Let's leverage that and think about new directions to take. So I've been thinking about how there are programs and services that work, but families often can't access them. And maybe if we do something about that, we can prevent adverse childhood experiences and child maltreatment. So, we know lack of access to healthcare and social services is consequential to child safety and well-being. Health and social inequality are associated with multiple, negative developmental outcomes. Effective services exist. So we need individual, organizational, and system level strategies to reduce barriers and engage these families and facilitate their connection to care. And the idea being that promoting and supporting access to prevention and early intervention services could reduce adverse childhood experiences and maybe even promote health and social equity. So that's leads me to my third study, which is really around family navigation to prevention and early intervention services. This is the paper that was just published this month in BMC Public Health. It's a navigator model that I developed from these previous two studies and also my practice experience working with families for a decade. The goals of the navigator model are to focus and engage families that are least likely to receive the supports they need, the ones who are most affected by health and social inequality. This was pre-COVID. I wanted to leverage technology to support these families because transportation and time are a premium for families. And so, a technology-based model was something I was really interested in. It's also brief. The model is brief, low cost, and hopefully easy to install in routine settings. The idea really is to create something that paraprofessionals or bachelor's educated professionals could use effectively, something that wouldn't require, intensive clinical training. We also wanted something that would be applicable to culturally and geographically diverse contexts. So something that could get exported to our refugee communities here in the Twin Cities, but also work well with the rural communities here in Minnesota. And really focusing on prevention and early detection of mental illness as a way to prevent ACEs. And we drew off of our social work profession, philosophy of practice, empowerment and advocacy, social justice, anti-oppressive practice, really focusing on self-efficacy and self-determination as driving principles, and equifinality, basically that we could improve mental health and prevent ACEs through many different means, that it wouldn't require a referral to a clinical service or to a psychiatrist, that we may be able to get improvements in mental health or help people in any way that they felt that would be appropriate for them. And how we did this was through a comprehensive initial assessment. Took about an hour of their service needs, current services, service barriers. We engaged in collaborative service planning, basically helping the primary caregiver decide on the top 3 services that they felt were needed for their child's mental health to improve. We engaged in personalized service research, checked in with them every week, did problem solving, progress monitoring, and then a closing assessment and discharge plan. The total duration of navigation services were 12 weeks. In first and last week were assessment weeks, and then the 10 weeks of intervention between. It was a proof of concept study, so we were really just looking to see if, like, could we build something like this? It exists in hospital systems. Navigation, you know, to oncology care or other specialty healthcare, this type of services exists for a while, but I really wanted to see if it could work with, like, the people here in Minnesota, the caregivers of children here in Minnesota who are not in contact with any healthcare or social services and need them. We also wanted to look to see if we could identify some core components, kind of get at some mediating mechanisms, either within the intervention itself or within the parent that might be responsible for service engagement. And then take a close look at the ecological contributors to service need and service access. This is preliminary work, so we're really just getting started at this point. It was a formative evaluation with just one group. We didn't randomize people to treatment or control. Measures occurred through a pre-test, post-test at week 1 and 12, but then the navigators also collected fidelity of implementation data. I had them record all of their activities, as well as notes, anything they did on behalf of a client or on behalf of the project. The activity got described and the amount of time they spent on the activity got recorded as well. So we had a caregiver self-report and navigator self-report of the intervention, and then we conducted a mixed methods analysis of the data. We recruited folks from the community partners that I mentioned earlier. Sherburne County Health and Human Services was a great partner. They people in their income supplement program, basically any health or human service program in Sherburne County that had contact with children before the child maltreatment investigation process was notified of the study. Intermediate District 287 was a recruitment partner. We delivered this to their online school, which I think served 12 school districts in Minnesota. Washington and Ramsey County Head Start gave flyers to parents, and we did a Minnesota Public Radio campaign. But by far, our most effective strategy to recruit parents was through social media, specifically Facebook and Instagram. We had, by and large, that's how families felt most comfortable talking to us and engaging with us. And we used their informed consent geotag to make sure that it matched the address where we were going to send their incentive card, to make sure that they were actually living in Minnesota. To be included, they had to be a primary caregiver of a child under 18. That child had to have unmet mental health care needs, and the family needed to be experiencing what we considered significant and persistent barriers to needed care. And that was really like a 5-minute interview with the parent to kind of talk about what they've done, what efforts have they tried before, and what if it was significant enough to require enrollment in a study. They could not be currently receiving case management services from any of the systems in our state, and they plan to reside in the state where the study was conducted here in Minnesota. We had pretty good interest. 50 participants were assessed for eligibility. 16 were not eligible, 2 declined to participate. We enrolled 32, lost 1 to follow up, and for family illness. 2 folks, they were homeless, living in their cars, and we were starting the initial assessment, couldn't finish the interviews, and never heard from them again. So we had 29 study completers. And this image here on the right-hand side recorded the types of needs that they reported. In the initial interview, you'll see mental health was really highly prevalent. I mean, 29 of the 32 that enrolled. Basic needs, healthcare and housing were the next most important or most frequently reported for the sample. And then at lower rates, transportation, parenting, childcare, and school-based services. So mental health needs co-occurring alongside these other very important basic needs, right? Food, heating assistance, transportation, housing, things like that. From a different set of literature that I reviewed, we identified barriers to care, barriers to services, and I created what's called a service barriers checklist. And we completed that with the client. What we found was, on average, families experienced 10 barriers to care in that initial interview. Between 4 and 5 family level barriers. These are things like we have disagreement about what needs to be done, or I don't have things like that. There's not enough time in the day. I'm not sure I need it. Logistical barriers. How far away is it? Is it on public? Can I get there through public transportation? Provider barriers. Do they speak my language? Do they share my culture? And then system level barriers. Does this not exist in my area at all? Like, are there no mental health providers in my area? So I thought that this was really, just descriptively really interesting. Often, referring families, we refer people and assume they'll go. And then here we have, on average of 10 different barriers to care. We did a number of, the sample was extremely diverse. Oh, excuse me. More than half were racial ethnic minority. Sorry, I'm not. And about half lived outside of the Twin Cities. We used the Parenting Stress Index and the Child Strengths and Difficulties Questionnaire, and then a number of other study-specific measures to kind of get at what's going on for the family. Here's our fidelity measures and open-ended questions. What we found was high levels of intervention engagement. 19 of our 29 study completers completed all 10 check-in sessions, and then 7 completed 9. So, high levels of engagement. And most of the activities that the navigators engaged in were with or on behalf of clients and not study related, which I think is also important in terms of like cost and time, where navigators should be directing their energy. Outcomes. We did find statistically significant improvements in certain rates of service access. So 2 out of 3 services in the service plan was the average. We found significant reductions in family and provider level barriers to care, and trend level reductions to logistical barriers. And if that just makes sense, if you're thinking about navigators interacting with caregivers, they're going to problem solve the things going on in the house. And they might also be able to problem solve the specific issues they have with the person delivering services. We did not really have much success with, transportation or making services available in areas where they don't exist. We did find almost or near trend level increases in parental distress, which I think was probably due to the comfort that the parent had with the navigator in the second assessment. Maybe they underreported in their first assessment and overreported in the second. But we also found significant and trend level improvements to children's mental health, specifically reductions in internalizing and total difficulties. So we have some thought that maybe just the act of navigation and connecting people to mental health care alongside basic needs in and of itself might improve family well-being and may improve children's mental health. I think it's, this is all preliminary data, so we have to exercise some caution. So taking all this work and have really, tried to engage our partners at the Department of Health and the Department of Health and Human Services. They're very interested in building public health approaches to mental health promotion and health equity. So what I'd like to do is maybe test the model in a randomized controlled trial design. We're doing some preliminary work with our partners in different settings here in Minnesota where navigation might be a good fit, or where they're doing some kind of navigation to really think about what is the next step for Minnesota in preventing maltreatment, promoting mental health, and reducing health equity. And that's it. I wanted to make sure there was enough time for a conversation, so I skipped a few slides. If you're interested in the studies, these are the citations. And yeah, let's have a conversation.
Yeah, that's great, Jeff. Thanks so much for that thorough, lots of details, lots of great history of work in child maltreatment prevention and, trauma-informed intervention. So that's wonderful. I wonder, maybe I'll start with a question. In the field, it seems like I was encouraged by your pilot. So, sort of the proof of concepts study there about engagement.
Mhm.
Because when I look at the child maltreatment field, it just seems to me there's always been sort of three recurrent problems in the field about sort of limiting the effectiveness of programs, especially home visiting programs. One, that most of the programs are heavily, the intervener is a paraprofessional and not a nurse or an MSW, social worker. If you take compare nurse family partnership versus healthy families, you get that strategy. So the paraprofessional model. The other thing is the duration of the program itself, or the dosage in hours, is really not very good, except in programs like NFP, which shows more evidence.
Mhm.
So that the issue of dosage, and the other thing just is the take up. And so I think what your pilot project showed was the take up engagement of families was high, but that's also a problem historically in the programs that have limited sort of the impact of child maltreatment. Like you could have 10 sessions or a 6-month program, but there's only a 50% participation rate, which is also very common in programs like Healthy Families. So that's sort of encouraging. But how do you think about, if we're not scaling programs that could have these long-term effectiveness? Your pilot addresses the engagement part, but how do you address in an online way or in a technology way the other problems, the paraprofessional, not that they can't be effective, and the dosage question, which means more comprehensive services? It seems like that's also a big feature. So how do you address all three of those challenges in the work as you
So
move forward?
great questions. The dosage, training, and then what was the other component that you were thinking about?
Uh,
Um,
just to take up, just engagement. So
yeah.
what you're doing, because that in the field, because there's a lot of work, and we've looked at different models, especially early childhood models of child maltreatment prevention, but that seems to be the issue. But you're encouraging evidence. So I just think about how do you scale those other features up? You can address engagement in your project, but how do you address these other more systemic issues that have always been with us?
Yeah, the great questions. So that one of the primary things that I'm trying to disentangle and understand is like what are the ingredients that we need to engage disaffected and underserved families? Like, how do you engage somebody, build that trust and support and rapport and motivation to make a change within a population that's disaffected? And I think that self-advocacy, self-determination, um, self-efficacy are sort of what I hypothesize to be sort of the driving
Sure.
mechanisms.
Sure.
And what I think the participants really appreciated about the navigator model that we evaluated is that the philosophy is like, this is, what do you need? What do you think will get you better? What do you think will get your family better? And we'll work with that. And I think that's a fundamental change.
Yeah.
My observation of systems is like, we'll give you something, but there's a payment required in terms of time or effort, or so this is much more like a light touch if they want a light touch. It's family directed. And the question about dosage, I do think that this could be and probably should be tested in an adaptive design, because the people who got 6 sessions versus 10, I don't know if the people who got 10, I think they might have just been good compliers, and maybe didn't need that many sessions to get the benefits. So, it could be a lighter touch. There are navigator models that are like 1 to 3 sessions that have shown efficacy in like emergency room settings. So I think that, maybe that's a question to explore. I think, and the other piece, I'm just initiating a needs assessment of navigators working in different sectors here in Minnesota. So our community resource hubs, our parent support and outreach programs, our community health workers. We're going to survey and interview any and all of them, really anybody who's willing to talk to us about what is the practice wisdom, like what do people know, what's working for them. And then I'm also going to assess their attitudes towards evidence-based practices, and their feelings of self-efficacy, because I think that those will be important training elements. Like if you go out into a community and you're like, look, these 5 things will work, or these things have shown to work, in research, I think that, some communities may not appreciate that. So that's kind of the question, is like distilling the core components, distilling the things that have to happen, finding ways to train people in that. And then if we're doing research to test it in a randomized trial, but also with a, sequential multiple assignment, or some kind of adaptive framework that allows us to kind of figure out how much for whom and under what conditions.
Sure. So this could be built, a light touch approach. It could lead to, more of an acceleration, or be a catalyst for larger changes, which I think is great. I think that's a great way to think about it as well. And I think these bigger challenges have been with us, and this is encouraging. So I am encouraged by what you're presenting. So let me open it up to others. I know we don't have a ton of more time. Other kinds of questions. I have other questions, but I'll leave it to others. Other questions people have. Or thoughts.
I have a question. So you have these different interventions. Have you thought about, doing any kind of cost effectiveness or benefit cost analysis?
Yes. And I do have, that data, just in terms of like what my effort and my research assistant's effort cost. So I think I haven't done that yet, but I should. It wasn't very expensive. It was delivered during the pandemic. It just so happened that this remote model got off the ground right as COVID happened. So it just fit. It was a good fit. But you only need like a computer, internet access, a database, and then time. So it should be low cost, but I'll need to do that cost analysis for sure.
Yeah. You can also check in with Judy on that. She could help you on that.
Cool.
Is Nishant here too? Nishant, we have a lot of us like the cost effectiveness approach, so we do that as well. But other questions, the other thing too is that if you embed this navigator model within existing programs, think about it, because I don't think you review some of the reviews. Like there is encouraging research from early Head Start and Head Start that programs, comprehensive early childhood programs, we have one, the Child Parent Centers. If you implement them well, that can also prevent child maltreatment. And there's some interesting studies. And these are like programs that are already infused within school systems and other sort of systems. So you could sort of piggyback on that with this navigator model, or just looking at the broader field. So just looking at other avenues of child maltreatment prevention could be of interest. And those are more primary, prevention. That might be encouraging. You might want to look at some of the early Head Start studies of that. I can share a couple with you.
Early Head Start navigation.
Yeah, and not navigation, but early, in terms of preventing child maltreatment. Like early Head Start. I mean, there are really school readiness programs, right, or parenting programs, but actually, there's evidence that they actually can prevent child maltreatment. So, and then if you build a navigation model on top of their family services, that could enhance the programs even further.
Yeah, I really appreciate that, Arthur, and
that could be interesting.
Had talked to people in Head Start programs, and I do think that part of this is also like systems linkage, right? Like we want to get kids and families connected to early Head Start because we know it works, but then also how do we improve communication, across the different sectors that work with Head Start. So that's a great idea.
Yeah, that's great. No, it's follow up, and there's a lot more to talk about. Anything else? Let me just check. Anyone in the chat had, I don't know, someone said something in the chat. Else, no, we should be okay. Any other questions? I know we're winding down. So in the future, so you're going to be in your model, navigation model, is your next step in the next few months is to just build on this navigation model, or are you going to do any more kind of research?
So I'm trying to create a treatment manual that kind of describes the process of navigation and what people need to know. And then I'm also working with our navigator communities here in Minnesota to assess their motivations and interests, and maybe doing some like a field trial really, I think would be the next natural step for this. So
Right.
yeah, so more investigation into mechanisms, training approaches, and community partnerships. That's, I'd say, the next 2 years probably what I'll be working on.
Yeah, that's great. No, keep us posted. So we have a lot of data, sort of ACEs and early, various kinds of, prevention intervention strategies. So there's certainly more to talk about.
Yeah,
As
I'd love
well.
to continue that conversation and find ways to collaborate. Let's
Yeah,
do
yeah, absolutely. That's really great. Okay, well, Jeff, I really want to thank you. If you send your slides through, we post
Yep.
them, and then we'll just continue the conversation in all the work that we're doing.